Hi, my name's Eli Potts. We're here with Tom and Courtney, and today we're going to be doing a patient assessment and management on syncope. So I'm just going to have a chat to Tom, and then we'll walk through what our assessment and management is. So Tom, can you please just tell me what happened today, mate?
Sure thing. I was just cutting up some carpet and sliced my finger open with a knife, and I saw my own blood and just fainted. I guess, I'm not sure, blacked out, and then woke up.
Okay. Thanks, mate. Courtney, do you mind just grabbing a few bottles for us, and then I'm just going to ask Tom some questions. So, Tom, I just want to reassure you that syncopes, they're really common in the general population. They happen to about half of us. So it's just a transient loss of consciousness, but there are some serious implications that may cause syncope. So I just need to ask you a few more questions around that. So, first thing first, have you ever had this happen to you before, mate?
Yeah. Just the only other times it's happened is when I've similar event when I've seen my own blood.
Right.
I tend to pass out.
Right.
But not when I see anyone else's blood. It's just mine for some
just
reason.
your own. Yeah, that's quite common, mate. You feel a little bit wheezy,
Yeah.
knowing that blood's supposed to be inside of you. Do you or does your family have any history of a chronic heart disease or valvular disease or anything like that?
No real heart problems in my family.
Cool. Before you had the syncope, did you have any chest pain or palpitations or anything like that? No, nothing? Okay. Currently, are you feeling short of breath or...
No,
do you
feel a bit hot, but...
Do you have a headache or anything like that?
No. Like I feel pretty normal, like not lightheaded or anything.
Okay.
Yeah.
When's the last time you ate something, Tom?
Would have been lunch, maybe an hour ago.
Okay, cool. That's good. And you don't have any other medical conditions that we need to know about? Epilepsy or heart disease or anything like that?
No, normally I'm just pretty healthy, like not on any medications or anything either. So
it's good. Cool. Alright, and do you have any pain anywhere from syncope?
No. It's just like I said, I just feel a bit hot, but otherwise I'm pretty normal. Yeah. Obviously I like a little pain on my finger, but that's it.
Cool. Alright, so we have talked to some of the witnesses from this incident today, and they've discussed that Tom did have a fate after looking at his own blood, and that he was only out for approximately 15 seconds before he came back to. They did notice that he did look quite sweaty and pale, which is quite common, again, for a typical syncope. So what we really need to do in our assessment is just rule in or rule out if it's a typical syncope or if it's atypical. So the major problem that we have to come across is ruling in or out if it's cardiac related. So I just need to talk to Courtney about some of our vitals, and then we can start thinking about our management plan. So Courtney, what have we got?
And we've got blood pressure of 130 on 80. We have a heart rate of 70, a temperature of 36.7, and a BGL of 9.2.
Okay, cool. So did you have a look at the 12 lead?
Oh yeah, I did one before.
Yep. What did the 12 lead read?
12 lead looked good. We have no obvious, just sinus rhythm, no obvious.
Okay, cool. So having a talk to Tom and looking at all the vitals, I can sort of safely rule out that it's an atypical syncope, just on the basis of the events prior, how it's a common trigger for most people to sort of have an environmental syncope where they see something that scares them, and that stimulates like an autonomic activation. And Tom safely told me that he doesn't have any history of cardiac-related diseases, nor does any of his family. And I've worked through some of the red flags that are in our CPG books, just going around headaches and shortness of breath to rule those out. And I'm quite happy to rule out that there's any abnormal vital signs as well. So just double checking once again with all of my red flags. Tom doesn't have any abnormal vital signs. He seems to appear back normal, like you feel fine.
Great.
There's nothing abnormal on his 12 lead. He has no shortness of breath. He doesn't have any injuries related to the syncope. The syncope didn't occur during exertion. It was only triggered by an emotional response. He's obviously not pregnant, doesn't have a headache, and there's no history of valvular or congenital heart disease. So I can safely rule out atypical syncope. So for my treatment plans, I'm happy to leave Tom at work here so that he can continue going on with what he needs to do. But something that we always consider is our non-transport checklist, which is also found in the back of our procedures. So this is just another safeguard to enable or to ensure that we've covered all of our bases and that Tom will be safe to be left at home.
So I'm Courtney and we have my offsider Eli and our patient Tom here today. So today we're doing an assessment of non-traumatic lower back pain. So with the symptoms of lower back pain, we're trying to put them in 3 different sections, and these include non-specific, which can be our musculoskeletal back pain, then we have our sciatica, which is quite a common complaint, and then we have our third one, which these symptoms don't fit into either, and it can be some sort of more sinister complaint. So with our assessment, we'll get a full set of vitals, so I'll get Eli to do that for me,
Sure.
and then I'll run through some history taking, and we'll get some more information from Tom there. So Tom, can you tell me what's happening with this back pain? How long has it been there?
Well, about 2 weeks ago, I was putting the bins out, and I went down and twisted weirdly, and
Okay.
then just had a sharp pain, and it's kind of been there ever since. Yeah.
Okay, and you haven't had any problems with back pain before? You've never had any other issues with your back?
No other issues.
Okay, so it's just been this last 2 weeks?
Yeah.
Alright. And this pain in your back, whereabouts would you say it is, and does it go anywhere? Radiate?
It's down in the middle of my lower back, and like sometimes I can feel it down on my hip, but that's the only other
Okay.
place. Yeah.
Okay, anything making it worse at all? You're not noticing?
When I move, it
Okay.
hurts.
Okay, and out of 10, what number would you give this pain? How bad would you say it is?
Like a 1 normally, and then when I move, maybe a 4.
Okay, and you've been well otherwise? Don't have a cold or flu? You're not feeling coughing or feel sweaty or anything like that?
No, I've been pretty good over the last couple of months. Yeah.
Okay, lovely. So we'll do a full assessment and we'll try and work out a plan from there. So Eli's going to get his full state of vitals, and then we may lay you back, have feel your tummy and your back as well. Do you have any pain in your chest and your tummy at the moment?
No,
Okay.
This hurts.
So Eli will do that for you.
this doesn't hurt.
Okay, so nice and slowly we have a quick
Sorry,
feel of
this
his tummy. So when we're talking about pain in our chest and our tummy, we are
Any
trying to rule out
No
any
pain.
sort of
I'll sit you
aneurysm
back
or
up.
dissection that can be more concerning. So checking out our vitals and getting a full assessment. How was his back and tummy?
So the tummy was soft to touch, no pain or palpation.
Okay.
Any pain in the back here?
Just in the middle.
Just
Only
right
in the
here?
middle. Yeah.
Okay. And it's not in the bone, it's more the muscle, is that correct? Like is it sore on the fleshy part? Or is it
One
The
side.
fleshy part. Yes.
cool?
Okay.
Towards the right side.
Okay. So Tom, I'd just like to have a quick feel of your feet, check for your pulses, and then we'll do some strength tests. Is that okay?
Sure, that's perfect.
Okay. So I'll just have a feel of both of the pulses. Both nice, strong, regular. So I'll get you to just push both your feet up towards me there.
Yeah, sure.
Lovely. And we'll push them down. Okay. And no tingling or funny sensation in your legs at all?
No,
No lack of sensation in your saddle area around your groin or anything like that?
nothing like that.
Okay. And how's your mobility in those? Can I get you to wiggle both feet for me? Doesn't feel abnormal at all?
No, it feels normal. And mobility's been pretty good. I've just been doing all my daily tasks as normal.
So just a bit harder to get round kind of thing?
Yeah.
Okay. And have you been getting up and moving around a bit when you can?
Yeah, when I can, like I'm pretty stiff in the morning, but it just gets better throughout the day.
Okay. So just with our back pains, it's really, really important for your musculoskeletal back pain, which it sounds like you may have here, to keep your mobility up and try and get up, walk to the kitchen every half an hour just to loosen things up. And
Okay.
probably
I'll try
don't
to
feel
do that.
like it, but we can.
Yeah, if that's what's best for me, I'll have to do it.
Okay, so with a patient that's got a lower back pain issue, we need to run through our red flags to try and work out that everything is going fine here. So what's our vitals there, Eli?
Okay, so everything sort of checks out normally. His temperature is normal 36.6, blood pressure is good, 130 on 80, normal strong heart rate at 70, regular, rest rate 16, capillary flow peripherally is 3 seconds, essentially 2, and the 3 lead came back with a sinus rhythm.
Okay, and so your bladder and bowels control has been normal, no incontinence or any issues with that?
No, it's been pretty normal.
Okay, and so we don't have a temperature above 38, so that can help us rule out some sort of spinal infection, because if they're post-surgery or had a recent epidural, that may be a particular particular reason for it. He has no rigors that are obvious, which will also tell us some sort of infection's going on. All vital signs are normal, so we have no pain in the chest or thoracic spine, which is good. We have no abdominal pain or tenderness. We've got no altered sensation in the saddle area or either legs, which may point towards our cauda equina or some sort of spinal cord issue. No altered sensation. He's got normal power in both legs. He's able to walk. Got no signs of symptoms or of generalised illness, and no pain radiating down both legs. So I'm not thinking it's currently sciatica, and he has no history of it. So I'm quite happy to leave Tom here at home at the moment. How would you feel about staying home and managing everything at home?
I'm very okay with that.
Okay, so you see the pain was about a 2 out of 10.
Yeah.
Have you been taking any of your own pain relief or that sort of thing?
At the start, I took a bit of paracetamol, but nothing recently.
Okay, and you're managing, so you don't want any more pain relief currently?
No, thank you. I'm alright.
So patients with lower back pain, that's mild pain, we start with our paracetamol and our ibuprofen, tramadol, and then we can start escalating. We can use Pphc if we need to get them mobilising, and then we can start considering other opiates and also low-dose midaz. We can consider calling for that if we're not getting anywhere with the back pain, because it can be really, really uncomfortable and really painful for these patients. So leaving him at home, I'm happy with all my red flags. I go through my non-transport checklist, make sure I see him mobilised around the house so we can ensure that he does have normal mobility. We'll get a second set of vitals, and then we'll be able to leave him here, making sure that he's happy with everything. Have you been to the GP or physio or anything like this?
No, not yet.
Okay, so it may be a good idea to go see a GP, and he might pop you through to a physio to see if there's any exercises or mobility things that you can get you back on your feet earlier.
Okay, I'll try that.
Awesome. So you're happy with that?
Yep.
Lovely. All the best then.
Hi, my name's Tom. I'm here with my patient Eli and my offsider Courtney, and I will be doing the Epistaxis scenario. So Eli, what have you called us here today for?
Well, I've had a bit of a blood nose for the last, 45 to an hour.
Cool.
And I just can't seem to stop it.
Yep.
It just keeps bleeding.
Cool. Okay. Is that the only thing wrong at the moment? Do you have any pain elsewhere?
No pain elsewhere.
Did you hit your head at all?
No, I was just sitting on the couch watching TV, and then it just suddenly came on, and yeah, it hasn't gone away.
Okay, cool. So immediately, can you just do a set of vitals, mainly focusing on sort of cardiac related vitals, so our heart rate, our perfusion status, and our blood pressure, and I'll just do an immediate intervention here. So can you just sit forward for me?
Yep.
And then just press exactly what you're doing on the fleshy part of the nose, and
Yep.
see if that helps with the bleeding. I'm just going to ask you a few more questions.
Sure.
Right. Do you have any allergies?
No allergies.
Are you on any medications, specifically any anticoagulants?
No, I don't take any medications.
Okay, that's great news. When was your last meal?
I was eating just before dinner time.
Okay, so what about the past medical history? Anything of note?
I have had a few blood noses before, but nothing else. I'm really quite healthy.
So what, those last couple of blood noses, what was the outcome? Did you go to hospital or anything like that?
Yeah, no, I got them dealt with by my doctor. He cauterized
Alright,
it.
cool. Make sure you stay with that. That's alright. Alright, cool. So that was dealt with at your local GP.
Yep.
Have you had any sort of recent trauma to your face? I must stress this.
No, I haven't. I've literally just been sitting here tonight on the couch.
Cool. Alright, that's good. Nothing in the last couple of days, nothing to the back of the head,
Nope.
nothing interesting like that?
Nope.
Alright, have you had any sort of surgery to your nose, to your sinuses, or to your brain?
No, nothing.
Okay, so that's really good. So we've ruled out a few of those risk factors, and while Courtney is doing the vitals, why have some of those vitals come back as
We have blood pressure of 125 on 95 and a heart rate of 90.
Okay.
Temperature was just 37.8.
Okay, that's good. So I know that he's not febrile. He's also not elderly, which is another couple of risk factors for dangerous epistaxis. He is maintaining good cardiac output, looking very well perfused. His tone looks really good. He is maintaining really good central and peripheral perfusion, and he's not hypertensive, and he is not hypotensive, which can happen in severe epistaxis. Now, we're going to look at what is the cause of the epistaxis and how severe the epistaxis is. So the important thing is we determine whether it's anterior or posterior, and if it's mild, moderate, or severe. So an anterior epistaxis is the more common. A
attributing to 90% of epistaxis and occurs by the septum. If I could just observe this for a sec. So I'm making sure there's no septal hematoma. The posterior epistaxis is the dangerous one that we have to worry about. So can you taste any blood at the back of your throat? No, you're not having any sort of breathing difficulties, nothing
No, just blocking my nose, that's all.
Okay, perfect. Yeah. So it does sound like an anterior epistaxis, and it is a moderate flow. So for this, intranasal adrenaline is indicated. So Courtney, can I just get you to prepare 1 mg and 10 mils adrenaline for me with an MAD on the end?
Okay.
And make sure you drug check with that with me.
So adrenaline 012, 18, 1 milligram and 1 mil. Check that one for me. So I'm drawing it into a 10 mil syringe.
12, 18, 1 mg, 1 mil. Perfect.
Yeah, cool.
How's that holding up? Is that still bleeding quite a bit?
Yeah, it's just kind of I just can't clot it.
Okay, that's right. So before we give this, what we're going to do is we're going to have you blow your nose to remove any sort of clots.
Yep.
And then when we administer the adrenaline, you're going to take a big sniff in.
Yep.
So that it all stays nice in your nose.
Alright.
Okay, after that, we're going to assess, see if the bleeding stops.
Yep.
If it's still bleeding after 15 minutes, we have the option to re-administer another 0.2 mg of adrenaline in each nostril.
Yep.
And if that doesn't stop it, we have a more intense measure, which is nasal tamponade.
Alright.
Okay, so I have 1 milligram and 10 mils there, and I've
Yep.
labelled it there. It's all drug checked and ready to go there. I've got my MAD attached.
Fantastic, correct, all labelled 10 mils. Okay, here we go. So now I'm going to administer 0.2 mgs of adrenaline in each nostril. Right, here we go. Blow your nose out for me. Good. Right, take a big sniff in. Here we go, 0.2 in one nostril.
Okay, so it's normal for all it to come out and dribble a bit for a second. Feels a bit funny, hey?
Very weird sensation.
And then we're going to go 0.2 in the other nostril.
Oh yeah,
Perfect.
that's good. That's good.
Okay, next.
Now,
I'll take that off, yeah?
Now you're going to hold the fleshy part of your nose for the
Yep.
next 15 minutes, and we're going to see if that works. Make sure you stay sitting nice and forward.
Alright.
Alright. So it appears that the bleeding has stopped.
Oh, it's worked.
Great. That
Look
is
at that.
great news. So, are you comfortable to stay at home?
Yeah, more than competent to
Okay,
say.
great.
Yep.
So he's a competent individual and meets all the non-transport checklist criteria, which is great. But because we have administered adrenaline, you must see your GP in the next 2 hours.
Okay.
Right? So
That's
make your way when you're comfortable, but it has to be today and it has to be in the next 2 hours.
Yep.